And I want especially to thank Dan Martin and Tamer for inviting us and for organizing all the Congress. Also, a special thank you to Cathy Byrne and Asgi Fazle-Abbas for the research grant evaluation. So it's my pleasure today to present you the impaired endometrial receptivity in adenomyosis. First of all, is uterine adenomyosis associated with poor IVF outcome? Well, when we have a look at the literature, you can see there is a list there of meta-analysis between 2014 and 2023 by many well-known authors, and we can conclude that in general there are less clinical pregnancies, less live birth rate, and also more miscarriage due to adenomyosis. What are the potential mechanisms of adenomyosis-related infertility? So, starting with the immune cell accumulation, I believe that we have seen in the titles of the grants also that immune cells is doing a lot in endometriosis and adenomyosis. So they produce an inflammatory environment that is hostile to the embryo and also too much oxidative stress. Thereby, it will induce endometrial abnormalities with altered window of implantation and impaired endometrial receptivity. Due to this, there is a hyperperistaltism locally with hampered uterotubal sperm transport, and also that the embryo is unable to implant. Consequences of this triad is a decreased rate for embryo implantation, lower clinical pregnancy, higher miscarriage rate, and risk of pregnancy complications. So, going back to the definition of endometrial receptivity. When we look, it is defined as that period of endometrial maturation during which the trophectoderm of the blastocyst can attach to the endometrial epithelial cells and subsequently proceed to invade the endometrial stroma and vasculature. You have seen that I put in red the epithelial and the stroma. So during my talk, these are the two fields we will explore together. So we are there with a window of implantation around day 21, and you see on the summary that there are 3 phases for the embryo to implant: apposition, adhesion, and then invasion. That's what women seeking for pregnancy are waiting for. And you see that in both are some markers like PR, progesterone receptor, oxaten, LIF, pinopodes, we will see together what it is, osteopontin there, LIF and prolactin. So these are the markers, the bold one, that we will analyze in our study that I will share with you today. First question, are markers of receptivity differentially expressed in adenomyosis and healthy endometrium during the menstrual cycle? So let's have a look at this retrospective study on paraffin blocks. So starting with the progesterone receptor expression, you will see always at the left the epithelium and at the right the stroma part. In fact, we were speaking about window of implantation. So you remember day 21, secretory phase. So there we will focus on the secretory phase, and you see there is a significant difference between the secretory phase of healthy and adenomyotic patients in the stromal PR expression, not in the epithelium. Going on with the LIF marker, we will have a look at the secretory phase. Again, there is a significant difference between healthy and adenomyosis group. Osteopontin, we will see the same here. And oxaten, which is a very well-known marker for endometrial receptivity, the same. So to conclude, if we focus and we look at the secretory phase between healthy and adenomyosis, well, you see that the significant difference in all these graphs are only in the stroma and not in the glands. So to conclude that part, endometrium from adenomyosis patients is characterized by abnormal expression of receptivity markers, contributing to poor reproductive outcome in these adenomyotic patients. What we have seen is that stromal cells during the secretory phase appear to be predominantly affected. showing decreased expression of all of the markers that I showed you, so progesterone receptor, LIF, osteopontin, and oxaten. So to conclude, it is crucial to consider the stromal compartment if we want to investigate endometrial receptivity in adenomyosis patients. So that we are waiting for the final publication about the part I just presented now. But if we want to have a model, an in vitro model, to investigate endometrial receptivity in adenomyosis, because as you know, the window of implantation, especially in women who want to become pregnant, is very tricky to have biopsies, endometrial biopsies of these patients. So it would be nice if we can have an in vitro model. If you remember, we all know cell lines, 2D culture, very easy to handle, but there are two buts. They are not replicating physiological cell phenotypes, and they are not patient-specific. If we go ahead in complexity, primary cells, you can see them here, can be patient-specific because it's a culture coming from a biopsy, an endometrial biopsy from a patient, okay, patient-specific, but only suitable for short-term duration of the culture, and of course, they do not replicate the 3D in vivo architecture we have in patients. So nowadays there is a huge, it's a hot topic when we speak about organoids. What are these organoids? Well, they are in fact primary 3D cultures, and here you see a culture of epithelial endometrium. So it is only the glands that you can see here, and you recognize that these epithelial cells are forming glands. These are the rings that you see here. They more closely resemble the glands of origin. They have the possibility to propagate indefinitely, so you can have several passages starting from one biopsy. And a negative point, yes, I know, is that, as I said, these are glands. So what do we miss here is a stromal compartment. And I've just demonstrated to you that the stroma is also very important in the receptivity. So nowadays, we are trying to develop primary 3D assembloids, which means we assemble these organoids, glandular cells, with stromal cells. And then only we will be able to later have a good in vitro model for the blastocyst implantation. I'm sure you all have heard about spheroids. So just to be clear, for the difference between the spheroids and the organoids. So the mechanism of formation of both is very different. Spheroids are usually taken from cell lines, or eventually tumor cells. And you see it's just an aggregation of these, all the same cells that will put themselves in a spheroid. It's really good, the word. But you see here a necrotic core, and then the proliferating cells are pushed outside. So the driving force for the development of these spheroids are cell-cell aggregation and adhesion together. So there is no matrix that is needed, and the application is solid tumor research. A huge difference that you see here with organoids is the shape. They self-assemble into ordered tissue-like structures. So these cells, they will form like a gland with a lumen inside. And you see here that inside the lumen we can have the gland secretions. It's completely different from a necrotic core that you see with spheroids. Usually the cell origin to form organoids is stem cells or progenitor cells, specific from each patient, because if you have primary organoids, you start with a biopsy from the patient. The application are organogenesis, disease modeling including cancer, and specifically personalized medicine, because if you have a biopsy from one patient with that type of cancer, you can in vitro put your different medications and know if that type of tumor will be sensitive for that medication or another one. So it's a very hot topic in toxicology. So now we are going to generate endometrial, epithelial, and stromal assembloids. How shall we do that? So you see here biopsy, endometrial biopsy coming from the surgery room, and we will dissociate these cells into stromal cells. This is usual 2D culture that every lab is doing every day. And from the glandular part, we will form these glandular organoids in another culture milieu, of course. You see that the stroma cells, they like to have fetal bovine serum, they need serum. If you put the same medium for the glands, they will never grow. So 2 different medium after dissociation, and then afterwards, once these glands have formed organoids in the matrix, well, we will try to put them together and force these stroma cells to go inside this matrix and form these assembloids. So the aim is to have this communication, cell-cell communication between the glands and the stroma. And look here, this is a microscopic appearance of 1-to-1 volume in the matrigel immediately after plating. So you recognize the glands and you see there all around the stroma. 2 days after the plating, you see that the glands, they have grown in culture, they are bigger, and you see here in the middle even secretions in the glands and all around the stroma. But are these assembloids, do they really replicate in vivo tissue? So how can we see that? Well, we study the expression of epithelia and stromal markers in assembloids. Well, here you recognize CD10, which is typically a marker for the stroma of the endometrium, and you see all the stroma in brown here in a normal endometrium, and below you see CK22 immunohistochemistry that will put in brown only the glands. And we have the same in the assembloids. So you see that the CD10 stromal marker will mark only the stroma in our assembloids, and the CK22 only the glands. Is that piece of tissue there in the matrigel really the same as a piece of tissue in vivo? Well, histological changes in assembloids, are they possible after exposure to hormones? Well, yes. So here you see organoids that are non-stimulated. You see fibroblasts that are, you see the stromal cells that have a fibroblast shape. You see also a large in diameter glands with a thin epithelial layer and very minimal gland secretion. When we stimulate these organoids in vitro with progesterone, look what happens. These glands, well, they become smaller in diameter, but they have a round, basally located nuclei with abundant secretion here, and also the stromal cells, they develop a naked nuclei-like appearance. So we can conclude that this model of assembloids will do replicate quite well the receptive endometrium. There we go on. Will assembloids be a good model to study endometrial receptivity? Well, that is the purpose of the study I showed you now, taking 6 biopsies. Here we have from healthy patients and 6 biopsies from adenomyosis patients. We will isolate and culture, like I showed you, the stromal cells and the organoids, make endometrial assembloids from it, and then we will try to mimic the mid-secretory phase. So we will give to these assembloids in vitro beta-estradiol for 48 hours, followed by AMP, cyclic AMP, and progesterone for another 72 hours. Let's have a look together what is the aspect of these assembloids after giving them hormonal stimulation. Of course, we will take the same markers we developed for the first study, so we will have a look at glycodelin, LIF, and HOXA10. Then, interesting study with scanning electron microscopy. We will look at the pinopods, and then by ELISA, we will see if these assembloids are able to secrete prolactin. Next slide. I will wait for the picture on the left side, but you will see a picture of assembloids. Look here. At the left, you will see a picture of assembloids from healthy controls, and there below from adenomyosis patients. And you see in both, we will put progesterone, and you will see the secretion and the deciduralization of these assembloids. I said we will go through rapidly these 3 markers, and starting with glycodelin, you see that there is a significant difference after progesterone response between healthy and healthy plus progesterone in the glycodelin positive glands, and same with the adenomyosis assembloids. Well, they do respond to this stimulation with progesterone. Another marker that we used was a LIF, and so again we have a look after progesterone. There is a significant increase for the healthy patient, healthy assembloids, I will call them, and for the adenomyotic assembloids, the same. But in the stroma, we don't see the significant increase in leaf in the stroma for the adenomyotic assembloids, only from healthy patients. You see the healthy is there, but in yellow there is no significant increase with the leaf. And the last marker was Hoxaten. Hoxaten expression, well, you see again, significant increase in the healthy assembloids when we stimulate with progesterone, and in the assembloids from adenomyotic patients, there is no significant increase of that endometrial receptivity marker. I will end with some nice pictures by scanning electron microscopy. This is an endometrial tissue from a 31-year-old healthy woman during the mid-secretory phase. Look, by scanning electron microscopy, what it looks like, the surface of the endometrium. You know all these bubbles here, they are called pinopodes. Here you see endometrial tissue with these pinopodes in a healthy patient. When you take a biopsy and you put the tissue for SEM analysis, you see that you don't see these pinopodes in an endometrial biopsy from an adenomyotic patient. So this is in tissue. And I told you I want to see if these assembloids that were developed in the research lab are really representative of the tissue. And also we studied these pinopodes, and you see endometrial assembloids from healthy patients. We can reproduce these pinopodes at the surface of these assembloids. But if we look at the assembloids from adenomyotic patients, look, there are no pinopodes neither. So to conclude my talk, we can say that primary epithelial and stromal assembloids can be generated from endometrial biopsies from both healthy subjects and adenomyosis patients. These assembloids are responsive to hormonal stimulation, and they mimic quite well the window of implantation by expressing glycodelin, leaf, and oxaten, and also forming these pinopodes in vitro. Assembloids from adenomyosis patients showed a decreased immunostaining for leaf and oxaten and failed physiologically to develop these pinopodes. And to end, patient-derived assembloids may serve as an advanced preclinical model of adenomyosis-related impaired endometrial receptivity, opening up new horizons in understanding and treating the condition. I thank you for your attention.